In older patients, non-statin therapies are still being used for lipid lowering, sometimes as add-on therapy to a statin, sometimes as an alternative therapy. Bittner and colleagues have a very interesting paper in the October 27th issue of JACC exploring the use of lipid-lowering medications in more than 300,000 elderly patients with CHD using a cohort from a Medicare database. And I am with Dr. Michael Farkouh, who is one of the authors of this paper, co-author, at the Peter Munk Cardiac Center and director of the Heart and Stroke Lewar Center at the University of Toronto in Canada. First off, let's start with some background. Why did you decide to do this study?
Well, you know, Rick, we had the observation that some of these non-statin agents were not being used optimally, and there was a lot of confusion in the community about their utility. We didn't have large outcome in many of these cases, or going back to 2007, we didn't have outcomes data. Right. So we had surrogate data. We knew that these agents worked on the lipid profile. In the case of ezetimibe, it lowered LDL. In the case of niacin, it raised HDL. And so we had approved agents that had promise. And the question is, we wanted to document the utility and the utilization of these agents, and then correlate that to the publication of key evidence regarding these agents and how that affected the trends in use.
Oh, excellent. Okay, so you had 5 years worth of data to better understand these trends, and it was 2007, 2011. How did you conduct the study?
Well, it was done through a very unique process. We have at the University of Alabama, where Dr. Bittner works with a group, the epidemiology group, they have access to a random sample of 100 million people who have access to Medicare. So it's a random sample of 5 million patients of the 100 million. So it really is quite a representative sample of people over the age of 65. And so we then categorize people according to the year from 2007 all the way through 11, and then the agents that were used, whether they were on a statin drug, which is the gold standard, or not on a statin drug. Because remember, a lot of these drugs are used because you can't tolerate statins, or you can't even use them at all.
Now, in this case, you had a variety of things that I was kind of shocked to find. So tell us about some of the results, and then we can discuss some of these.
Yeah, well, I think there are two main bits of evidence here that we should concentrate on. One is the use of ezetimibe, which is this drug that lowers LDL. And its utilization, remarkably, in people who were on statins was less than 20%, who were not getting to target. And in people who were not on statins, only about 5% of the people were on the drug. So you can see that there was what we thought was an underutilization of what appeared to be effective on the biomarker. Now, the problem was in and around, I think it was around 2010, there was a publication of a paper looking at carotid intimomedial thickening and showing that it was called ENHANCE. And this trial demonstrated or suggested that there was no effect of ezetimibe. So then we got into the question, is it LDL lowering or is it statin versus ezetimibe? Right. And this led to a rapid decline in the use of the drug in these populations. It went from modest use to very low utilization. Now, as you know, it was vindicated just this past few months with the publication of Improve It, which showed that even with each incremental reduction of LDL cholesterol, whether it's on statin or ezetimibe, you enjoy a benefit on CV risk. So it showed us that we were affected by the surrogate marker study, did not wait for the larger trial to report. And I guess now we should see a trend in the reverse direction. With niacin has been promising right back to the Coronary Drug Project 30 years ago. But in recent trials in 2011, the AIM-HIGH trial and the HBS2 from the Oxford group, Heart Protection Study 2, suggested that niacin does not work in patients who are on statins. Right. So that's the caveat, who have low LDL levels. And so we saw also a beginning of a decline in the use of niacin from under 5% to now under 1%.
So how about the use of statins?
Well, the use of statins, of course, has increased over time, but probably not to the levels that we would like. And we've done a partner publication about a year ago by Bob Rosenson from our same group, showing that there is underutilization of statins in patients who have coronary heart disease. And also there is a lowering of dosing. There's people on modest and low doses of statin when in fact the guidelines recommend high doses. So yes, the statin issue is still hot, and we're not getting patients to target, number one. We're not using the high-dose statins. In the AHA guidelines now, we say high-dose, low-dose, as opposed to statin LDL level, statin-directed LDL level. So the idea now is that we know that we're underutilizing statins as well.
Well, you showed some small improvement in the use of statins, but why would there still be 40% of patients not being treated with guideline-recommended therapy? And these are people with established CHD.
Yeah. You know, there are multiple reasons, but I think the most important reason is that patients claim, and their physicians claim, non-tolerance, intolerance of statins. Muscle aching, memory loss, some sort of depression. We've seen all kinds of complaints. We've also seen some evidence that it increases the risk of diabetes. We've talked about this before. But likely, the people who develop diabetes on a statin drug are people who are going to become diabetic in the next 3 months anyway, if you remember. Exactly. So the idea here is, I think it's a lack of education, and I think it's an issue of trying to convince our patients to take yet another drug, even though this class of drug is incredibly beneficial.
Well, you mentioned the high-intensity statin, but the changes in the percentage of these patients was modest, and we're talking a very low number of patients.
Right. That's right, over a 5-year period.
Yeah, that was kind of a shock.
Yeah, I think it was. That wasn't the point of it, because we already knew that, but yes, that's the background therapy, and we have to understand that whenever a new drug comes forward now, it's going to be compared on top of a statin. You're not going to compare it versus statin.
Correct. I mean, Peter Toth, MD, PhD, he wrote the accompanying editorial viewpoint entitled Treatment of Dyslipidemia in Elderly Patients with CHD. There are miles to go before we sleep. We have a lot to improve, right?
Absolutely.
He wrote, while we still have a lot to learn about residual risk and the role of adjuvant lipid-lowering therapy, quote, in the meantime, it is crucial that statins and adjuvant therapies with demonstrable efficacy be used appropriately in order to help more patients achieve guideline-determined goals for LDL reduction, especially among the elderly.
Yes, I think I couldn't agree with Peter more. I think that we have underutilization, particularly in specific subgroups, and it was demonstrated here as well that there was lower use of these non-statin drugs in African Americans, the elderly, and so on. So they tend to be the forgotten subgroups, and we have to remember that. And
there have been studies very recently within this year, 2015, that have shown that for people who are essentially at the very end of life, whether they're in a home or what have you, that they have only months to live, it's safe to drop statins in that situation. But for elderly people in general who are moving around and healthy, try to get a statin in there if they have CHD.
We have a study actually in review about the issue of frailty. It looks like statins, even in the frail patients, improve outcomes. But when you get to the very end of life with palliative care, we tend to back off on these preventative measures, largely because there are side effects, there are costs, and patients are looking for comfort. Exactly. So you're right. But in the frail patient, we still find that statins work effectively. That's important to know.
This is the October 27th issue of JACC. Please take a look at the paper and also the accompanying commentary. For Cardiol Source World News and Cardiol Source World News Interventions, I'm Executive Editor Rick McGuire.